So menopause, it is permanent cessation of menstruation, diagnosed after 12 months without a period. It is a natural biological process. Even though it's natural, it's not easy to go through. It comes with a lot of symptoms that, we could like safely say it's like a sickness, but it's not. The average age of menopause is 51 years, meaning that for most women in the United States at age 51, they should be in menopause. But it's a wide range. It could be sooner, it could be later. In my practice, I have a few patients who are like age 30, 32 to 35 that went into menopause early. We don't call it menopause, we call it premature ovarian insufficiency, and the way we treat them is different. But for the purpose of this discussion, we're talking about natural menopause, like progressing into menopause naturally. And then when we talk about menopause, we're thinking about cessation of the menstrual period. But perimenopause is also a very, very important part of the transition. Even though you're still getting your periods, or the woman is still getting her periods, there's still, once you start the transition, it comes with symptoms. For me, especially with the example that I gave, I wasn't fully menopausal at that time. I was still getting my periods, but they're all over the place. And for that reason, I did not receive the care that I needed. But it is a very important phase. It comes with a lot of symptoms, as much as the menopause symptoms as well. So this is a picture I wanted to show you about like the transition. So we're going to ignore the first part, and we're going to look at the early perimenopause. In that stage, that's the earliest part of menopause. It can last anywhere between 2 to 3 years. And at that point, the period is all over the place. It can be shorter, it can be longer, it can be heavier, it can be lighter. It's just all over the place, and it's unpredictable. And then going into the late perimenopause, that's the stage where the woman goes like 2-3 months without a period, and it's highly symptomatic as well. And then eventually go into full-on menopause. I do have a question for you. Once a woman gets into menopause, does she ever kind of finish menopause and like is done with menopause? No, it's lifelong. Good. Let's give her a candy. She won that answer. Let's go on, Sulani. All right, so don't click yet. So if I said, what are the symptoms of menopause? Who wants to take a gander? You can just shout it out. Okay. Okay, that's the first two that we hear mostly. Anybody else want to take a guess?
Maybe like insomnia.
Insomnia, that's muscle and joint pain, mood swing, yes. Well, you all got this. Well, that's good. All right, so click it on. And all right, so I want you to take a look at this picture. Everything you mentioned, everything you said is correct, but take a look at this.
Wow, yeah.
Wow. We'll just take like 5 seconds to look at that. There are things that you don't even think that it's menopause related that is on here. And this is not even like an exhaustive or comprehensive list of what it could be. All right. So we're going to look at Maria. She's 49. And she has no significant medical history, and she presents with sudden hot flashes and night sweats, and she wakes up drenched. We all know that it's hot flashes. In medical term, we call it vasomotor symptoms of menopause. And then, okay, so we kind of know what the definition is. It is sudden, it is intense, like really intense, you feel like taking off your clothes, and then the next minute you're cold again. And these symptoms can last for 7 to 10 years. imagine dealing with this year after year after year for about 7 to 10 years. There are different levels of it. It could be moderate to severe. It could be mild. We think of hot flashes as just hot flashes alone, but it's not just hot flashes. They're actually doing research and actually linking hot flashes to cardiovascular disease. So those women that have severe, moderate to severe hot flashes with the duration and frequency are going to are at a higher risk of cardiovascular disease. I want us to remember that. It's the #1 cause of mortality. I know when we think about menopause or hormone therapy, we're thinking about breast cancer, but it's so much more than that. Cancer is only like the next level, and I have a slide that I will show you. So treatment for menopause, the first line and the FDA approved, and the one that works best and the most is hormone therapy. It treats it beautifully. You get your life back. I have my life back. But with that being said, not every woman can be on hormone therapy for different reasons. It could be personal reasons, I just don't want to be on hormone therapy, or it could be they have some medical diagnosis like breast cancer, for which they cannot be on hormone therapy. There are other medications that we can use. So we have newer options of the non-hormonal medications. We used to use SSRIs, SNRIs. Those are medications that we use for treatment of anxiety, depression. They work, but not so well. They kind of decrease the severity of it, but they don't take it away completely. And they just don't work so well. These newer classes of medication, Bresdel, Veyoza, Linquet, they've been around probably around 5 years, I would say, and a lot of patients do well with it. I have a patient with a history, I have a couple of them, with history of breast cancer who cannot be on hormone therapy, who were just, dealing with it, and they're doing so well on this medication, so well, they don't have any hot flashes at all, so that's amazing. There are other treatments that are listed here, but one of them is that state-like ganglion block. I don't know who gets that, but it involves injecting into the spine to target the temperature control center. It works only for about 4 to 6 weeks. I think I'll take hormone therapy over that. If I have to go every 6 weeks to get my spine injected because of that, I'd rather do something else that works. Sleep and menopause. We're gonna skip over the story because we only have 30 minutes, so skip over that and then go to the next slide. So sleep is one of the major things that we hear about in menopause as well, the insomnia, the sleep disturbance. About 40 to 60% of women will have sleep issues. And most of them complain of waking up at night. For some reason, almost every woman says the same number. I wake up at 3 a.m. and I can't go back to sleep again. And my mind is just racing. And then I have to get up in the morning and go to work, and I'm tired all day long. Treatment for that, first line is cognitive behavioral therapy, especially if there's a lot of anxiety around sleep. Cognitive behavioral therapy would be the first line, and then maintaining a good sleep hygiene, cool, dark room. Sometimes we wake up and we're like, okay, I'm gonna pick up this phone and see what time it is. Yep, it's 3 o'clock, and now they start getting anxious. So you kind of really encourage not doing that. Avoiding caffeine, alcohol before bedtime, all those help. And if all these other modalities do not help, then we can go on to medication. I would like to point out that hormone therapy is not indicated for sleep issues in menopause, but a good majority of patients have sleepless nights because of hot flashes and night sweats. And once we treat that, they're okay and they're sleeping through the night and they're happy. About about mood, a lot of other symptoms that we hear about in menopause, it's anxiety, irritability, depressed mood, crying spells. Even if they don't have any diagnosis of anxiety, depression, and all those previously, they develop it at that particular time frame in their lives. And we think that it's caused by the fluctuation of estrogen and progesterone. And treatment for that would be cognitive behavioral therapy. We could do medication, mindfulness, manage the sleep issues around menopause, and sometimes they do very well. I would add brain fog to this. I didn't add it to the slide, but I'm going to lump them all together. A good number of patients come in and, we talk about this. They're like, I've never been anxious in my life, but now I feel like the world is caving in on me. I don't know what's going on, and I have this brain fog. I can't shake it. I can't remember things the way that I used to. We start them on hormone therapy, and majority of the symptoms go away. This hormone therapy is not indicated for treatment of any of this, but it's very helpful. For my patients that continue to have the symptoms afterwards, I strongly encourage them to seek either therapy or mental health consultation. But hormone therapy does help. I'll give an example of a patient of mine. She said, for years I felt like I was walking around with a blanket over the top of my head. Once I started hormone therapy, I have so much clarity. I don't feel all the things that I used to feel in the past. So it helped her in that way. And I want to focus a little bit on this because I don't know what the statistics is, but a lot of marriages or partnerships get broken around that time, around the menopausal time, because of vaginal dryness. So Susan here, she's 54. She presents with complaints of vaginal dryness and pain during intercourse. She reports a noticeable decrease in sexual desire, which has begun to affect her relationship. Her last penetrative intercourse was over 9 months ago. And as you can tell, she's already having a relationship issues because of that. So the vaginal dryness, the fancy term that we like to call it in the medical world is genitourinary syndrome of menopause. And that is caused by the lack of estrogen in the vagina. So what estrogen does, the vaginal tissue has a lot of estrogen receptors. In menopause, when we lack estrogen, it becomes thin, it becomes frail, it becomes dry, and it makes intercourse very, very painful. And also, because the bladder and the urethra are right within the same area, they have the receptors too. And so the patient is not getting enough sleep at night because now they're getting up many times to go to the bathroom because they have this sensation, I gotta go pee, and they go to the bathroom and there's nothing. And that is what this fancy term is. About 84% of women will have this. So the number is like really, really high. There's a wide range, but a good number of patients experience that. First line therapy, we encourage the use of moisturizers and lubricants. But we can also, if that is not helpful, we use low-dose vaginal estrogen, and that helps to rebuild the tissue and brings it back. I think there's a whole move in the Menopause Society. Maybe this might change. They want to they're talking about making the vaginal estrogen to be the first line, because lubricant doesn't rebuild the tissue. It doesn't do anything. It just apply, lubrication and moisture. So they don't think it's that helpful. Susan, we're talking about two things in one. Apart from the pain that she experiences, she also does not have desire. And so we have a fancy term for it as well, hypoactive sexual desire disorder. And it's just the loss of interest in sex. Just no interest, pain or no pain, I just don't feel like it. And it's very, very common in midlife in about 50% of patients. I brought this up because I want to talk really mostly about the treatment. For the longest time, the men in the house have Viagra, right? I think Viagra has been around for over 20, 25 years. And there's been nothing for the women, but now, we're now in the forefront and we're starting to have some treatment. So there's Vyleesi, it's an injectable that gets injected 45 minutes before intercourse. And I call it the female Viagra. It's not, but I just call it that because you inject it right before. And then there is ID, and that is like a daily medication. So for anyone having issues, there's help in that area. We use testosterone also, but off-label. Testosterone is not approved for use in women in the United States, but we use it off-label to treat sexual dysfunction in women. And the reason why I put this slide here is because I had a discussion with a patient of mine, and I was telling her about hormone therapy has been around for so many years, and she's like, how come we didn't know about it? Well, in the 1800s, they injected the tissue of cows into women to help reverse the sexual symptoms that is associated with menopause. I don't know how they did that, but they did it, and they saw that it worked somehow. So with that knowledge, they started now trying to isolate and synthesize estrogen, and by the 1930s and 40s, they were able to do that. Fast forward in the 1980s and early 90s, estrogen was widely used. Women were being prescribed, and they were doing so well on it. And there were some studies, they were very small, that are looking very promising, that it decreases cardiovascular disease and it also decreases the risk of osteoporosis. Remember, we talked about cardiovascular disease as the #1 cause of mortality. So they noticed that estrogen was doing that. Those women on estrogen at that time were not developing cardiovascular disease as much as those women who were not on that. So with that information, the NIH, next slide, the NIH decided to use that information and do like a study. It's a data-driven world. Everything that we do, we want it to be evidence-based, so now they wanted they had a female cardiologist, the first female cardiologist who was appointed to be the director of NIH. You know, it matters who is in power, okay? So she had that seat and she decided to do something good with it. So she initiated the Women's Health Initiative study. And what that study was supposed to do was to see the effect of hormone therapy on cardiovascular disease, because women were just, dying because of that. By 1993 or so, they enrolled women aged 50 to 79 into the study. And the reason why they did that was they wanted to see the effect not just on the younger group, but also on the older group. They also wanted to not be biased. So women who had hot flashes were not enrolled into the study, because then they will know who is on hormone therapy and who is not. And that informed their decision about the age. But then it turns out that the majority of women in the study were older women, so about 63%, about the average age of women enrolled in the study is about 63. So they started this study, enrolled a lot of women. This study was very expensive, cost about $1 billion to do, but stopped it before the study ended. So in 5 years later, they said they think that it caused increase in risk of breast cancer and cardiovascular disease. And you know what happened? We stopped. We stopped. Like when I went to school, They taught us about hormone therapy, but they say don't touch it with a 6-foot pole because you're going to cause, a woman to die or to have breast cancer. So didn't look at it, didn't pay attention to it at all until now. But anyways, even on the patient side of things, if I said to you, you're having hot flashes? Oh, wow. All right, so I'll give you hormone therapy. It will cure your hot flashes, but you can get dementia and stroke and heart attack and breast cancer. Who's going to take it? Yeah, because we have to discuss these things. We have to tell you the benefits and the risk. So if the benefit is just to manage your hot flashes, and then on the other side you could have dementia, a lot of women did not want it either. So even those women who were on hormone therapy before the result of the study came off of it because they don't want any of those, and I don't blame them for that. They looked back at the study that they did. If you look at those numbers in blue, those are women from age 50 to 59. And the risk for cardiovascular disease is so much lower, -2, and all-cause mortality is -10. And if you look at 70 to 79, plus 19, plus 16, plus 43, and same on this side as well. Hormone therapy, when started within 10 years of menopause, has like a very good outcome. And so when we talk about hormone therapy, it's more about prevention. We're not trying to cure, it's more about prevention of all the chronic illnesses that could happen as a result of menopause. You can move on. So that blue slide, just to summarize it, there was no increase in all cancer deaths. There's no increase in deaths from cardiovascular disease. And they also show that if it was started early on rather than later, the result is all favorable. So what happened with that study was, instead of separating by group, they just lumped everybody together. And then they decided that it causes cancer and it causes cardiovascular disease. But the truth is, the older you get, the higher your risk for breast cancer, the higher your risk for cardiovascular disease as well. So with or without hormone therapy, those women were 10, 20 years postmenopausal, and they were going to develop those illnesses anyways. But something great happened. We were all very happy about this. About 6 months ago, November of 2025, the FDA announced, because the study was revised and reviewed, the FDA announced the removal of the black box warning. So now I can prescribe hormone therapy without telling a woman that you have breast cancer and probably dementia and all of those. So we're very excited about that. The one thing that still remains as a black box warning, and we have numbers and studies to show that, is the risk for endometrial cancer. So if a woman is on hormone therapy, we need to oppose it with progesterone, so that risk is still listed there. I'll tell you a funny story from the last slide. A patient came, we had this whole discussion about hormone therapy, the benefits. I told her about the study and everything, and sent the medication to the pharmacy. She came back for follow-up. I'm like, how are you feeling? And she's like, I never took the medication. I said, what happened? And she said, well, I looked at the insert and the medication. It says it's going to cause dementia and heart attack and all that, and I didn't want it, so I didn't take it. I'm like, remember we talked about it at the visit? She's like, yeah, I remember, but it still says that. So we had another whole discussion to dispel that myth. So even though it has been removed by FDA, it's going to take a while for for all the inserts to change and all that. And this data is from 2023, and as you can see, heart disease is still top number there at 162.1 versus cancer. And this is not just breast cancer alone, it's all kinds of cancer. If we narrow it down to breast cancer, the number is going to be way, way, way lower than that. So hormone therapy, yes, a lot of women are afraid of breast cancer when it comes to discussion about hormone therapy. But statistics have shown that women who had breast cancer, it was caught early, they were treated, they have 99% chance of survival. And these women will go on to survive cancer, but die of heart disease. So prevention is better than cure. Eat healthy, hydrate, exercise regularly. Stress management, I don't know what that word is in this world that we live in. Sleep hygiene, make sure we're sleeping enough, at least 7 to 8 hours. Avoid triggers. Things like alcohol, caffeine, spicy food actually triggers hot flashes, so avoid those. And supplements, for those that believe in supplements. Herbs have not shown much benefit at all. But this calcium, vitamin D helps with bone, and also omega fatty acid, another protection for the heart. And then partner support. Asia said very important. But yes, listen and validate. The symptoms are real. They're not something that your partner just thinks about and say, you know, I want to feel like this today or tomorrow. They are real. So validate without, you know, criticism or anything like that. And learn about menopause, because the more the partners know about menopause, the more they will be able to kind of show empathy to their partners. And provide support, communicate openly, and encourage healthy habits. All right, so these are chronic conditions that can happen as a result of menopause, and that is, again, why we're talking about prevention. So osteoporosis, when a woman hits menopause, we started losing bone density. Actually, hormone therapy has been approved by the FDA for prevention of osteoporosis. It doesn't treat it, but it prevents. And then we talked a lot about cardiovascular disease. I'm not going to beat that horse anymore. Metabolic diseases like diabetes, it's preventative against that. And then we talked about the GSM, genitourinary syndrome of menopause. And references, and then next. All right, so we're a new practice, and we need women to know that we're here. So if you enjoyed this presentation, take a minute or